Okay, Professor Tsai, please.
Thank you, Daryl, Professor Nahasi, and our distinguished guests. And I thank you, the organizing committee, to including me and my colleague to this wonderful event. And today we are going to introduce a kind of experiment, how international collaboration and exchange reshape the not only national identity, but also the way of professional practice in Taiwan. So in a sense, my talk is about pragmatic challenge to contemporary vision of professionalism in Taiwan and the Western countries. We tend to propose and evaluating situational and relational learning paradigm based upon community mental health. And you may ask me why community mental health? Because in the past, Taiwan is expert in doing public health, especially the community health networks is very solid and since the 1950s. So Taiwan will be was the first country earned the reputation of malaria eradication in Taiwan, and also later on for the for the family planning, he earned the title in 40 years as a world #1. So which is all based upon the commitment of the health professional to their community work. And later on, we developed a community mental health where we established our health delivery system in 1980s. And finally, we find that in the time of the cost containment and the rise of free market, I think that we are under great stress in the sense of the value of a community is eroding from time to time. However, our mental health professional is able to put their own endeavor to save the mental health care system in Taiwan, even right now, 20 years after we have a universal health insurance. I think that the health delivery system right now in Taiwan is really fragmented and problematic because there are lots of too many medical centers in Taiwan, and there are also the community hospital. I think that the number of community hospitals has significantly decreased in past 20 years. So, which means that we do not have a sufficient mid-ground infrastructure to support our community health work in past decades. But however, for community mental health, we provide another story which might be a little bit different from our national policy. So I think that we have run the kind of community mental health international exchange and training workshop for 10 years. And the picture I show is a direct journal. This year, last year will be the first time in Taiwan we established a Department of Mental Health under the Ministry of Health and Welfare. And so I think it's a really important milestone. And I acknowledge that which will be a great contribution and persuasion from our international friends. And in the workshop, we have the various kind of field trip. And also, they go to the different kind of shelter demonstration site where those kind of small shop gas stations are running by severe mental ill patients. And those are part of the network supporting our patients or supported by their family groups. And later on, one of our presenters, the Superintendent Yu, he is also a leading figure in promoting the kind of social welfare network in Taiwan. And I think that while people travel around Taiwan, we begin to find that in the era of political uncertainty, or year of social upheaval. We think that under the threat of social turmoil, the institutional-based community supported network become a kind of common value shared by all participants from different countries, especially the one, the building with the grand piano shape is one of the leading child development center in Thailand. And also, you can see that how various kind of model with limited resources, however, in the region, they make a remarkable change along the way. I think that we appreciate those experiences shared in Taiwan that help encourage and become a very important motivation for our mental health professionals. They went to their country by their own money and try to see how we can learn from those least developed countries. I think the kind of experience change has been significantly changed the way how the mental health professionals in Taiwan show their commitment to people and to the society despite of the threat under the political uncertainty. So that will be the major agenda. In the kind of workshop, we share the major concerns and those concerns proposed by participants from different countries become a consensus that will be the working agenda that we learn from each other from year to year. And also we went to Lingham, the leading mental health and neuroscience institute in Bengal, India. Along the line, we think that how we help each other and persuade our nation in propose a good policy. Even probably the politicians listen little to us, we still have the power that we know where is the professional and social value are, and we support each other along the line. And so, in that sense, we fear that, well, the kind of patient's empowerment, which might be a part of a very important component in the discourse of bioethics since 1950 or even later, this institutionalization effort will be in 1970s. But however, even before, we find the significant discovery along the line of psychiatric medicine that as early as 1946, that there is the idea of therapeutic community has been popular, begin from Europe and later on become a very important desire and aspiration from the mental health professional even in the United States. But however, recently, under the stress of the militarism in terms of cost containment and in terms of various kind of hospital accreditation or ISO good performance index. So the kind of management concern has perpetuated a new sense of authoritarianism, whereas that we rely less upon the participation from the patient. So even the idea is old, but however, the practice right now is really problematic. So we can see in a therapeutic community in Western society now limited into a small group dynamics only for sometimes for substance abuse and sometimes for personality disorder children. So we think that which will be much limited than the original idea that the patient can take a part in their therapeutic protocol formation. So that's the way we think that the new authoritarianism will be very important part. The authoritarian contamination, what I say, the term contamination of the term therapeutic community not only deprives of a practical approach to a more humanistic and a democratic medicine democracy, but also promote a new variety of marginalization and the stigma threaten its development. So, and then we can find, with the development of the psychiatric medicine and also the idea of deinstitutionalization, we can see that all Western countries, their institution capacity decreased significantly since the 1950s. But however, here in Japan, there's only one exception, because when Japan has the money, they build an institution. So they put the red line is Japan, they put the other thing around. So, however, the story in Taiwan, later on we just know that, okay, why Japanese do that? Because Japanese government wanted to support every single family in Japanese society. They know what a hard time those families will suffer when they have a severe mental ill patient as their member. So along the line, when Japanese build the institution, which means that, well, the state have show commitment to support the family and the citizen in Japan, even the severe mental ill. So later on, we can see the long-term care system in Japan is well developed. But however, recently, statistically speaking, we find that if we put those numbers in the homeless shelter, including those numbers in jail, we find that in the US, it's exactly the epidemiological picture that those patients has been sent out, deinstitutionalized from the mental hospital. So in a sense that one very famous American professor informed me that what's shame for the American societies, they just use a prison house and they use a homeless shelter to replace the mental hospital in Japan. So, but however, in Taiwan, we don't have a significant institutional foundation for that purpose. But along the line, the mental health professional in Taiwan try a kind of middle way. We use limited resources, mainly based upon the institution, but we use the patients their own reserve function and build up with the support from their family those resources from civil society. That they build up a wonderful community oriented program for various kind for the patient in their various kind of rehabilitation stage. So that's the beginning of the Taiwan story. So the Taiwan become a picture that they try a midway between the Western paradigm and the Japanese paradigm. So here we think that nowadays the idea of patient participation or the ability to evidence the patient's reserve function is so important, because in the 1990s we have the idea of the evidence-based medicine, which means that you need a literature archive center to know what's going on in the academia. But however, in year of 2000, American scholar government find it's never sufficient. So they request that each institution have to establish their own data. Based upon the difference between their own data and the evidence archive, we can find what will be the major differences that should be the research topic. This idea, comparative effective research, become the central component with the rise of translational medicine. Afterward, in year of 2010, okay, thank you. The Americans think that while you have your own data, and then you have a literature archive, they think that you should disseminate the information to the patient. Later on, translational medicine get involved with the patient's participation. So which the new paradigm we call patient-centered outcome research. So along the line, we think that now doctor-patient or nursing health professional and the patient and their family's relationship were not one-dimensional. They form a kind of partnership in shaping not only for clinical practice, but also for larger scale translational research in post-genomic era. So, our approach is not new. The medical humanity reform and the way we form the ethics committee in the hospital, which also means that we change the slogan, the wisdom, the talent, the knowledge, power into two parts. One is that knowledge is shared with patients' experience. And the power is a participation. That is a way professionals should invite patients to take a part in shaping their decision making. So along the line, we feel that a kind of narrative identity approach that honor the narrative competence and the storyteller, which knowledge could be embedded in, will be an important foundation to share a new consensus, not only for treatment protocol, but also in a sense for a new community building that is supporting the idea behind things. So, wherein we think that the four topic approach will be very, very important because in terms of medical indication, which means that based upon what kind of collective wisdom that you may change your relation with your patient from citizen to citizen, advance a social contract between citizen to citizen to a medical social contract, which is between recognize the gap, a knowledge gap between both parties, and at the same time you take effort to manage the case. So medical education also means that how you inform the patient. And the patient's preference means that will be your responsibility to let patient know the knowledge and make a decision based upon the domain that is under the nowadays collective wisdom of contemporary medicine. So, in a sense, if their choice is outside the domain, that will be your responsibility to bring them back into what your competence could cover the kind of domain. Otherwise, your relation will be a citizen to citizen rather than doctor-patient relationship. So the key information here will be the consent. So based upon inform and the consent, you form a partnership. So the quality life of the patient is a common goal between both parties. And afterward, there is an idea of quality of life, but there is a social and the physical constraint. So what will be the social context that you may limit your highest goal, but at the same time, you have to struggle with, that will be the context feature that you have to pay attention to. So we propose, so knowledge should not teach, should not earn just in textbook. Knowledge should be practiced in the field. So we propose a practice-based research and collaboration along the line. So our approach provides sequential decision-making guidance, beginning with medical education, followed by eliciting the patient's preference, ensure the quality of life, and finally understand the patient's unique context. So we think that combined with narrative analysis, Joseph's approach allows us to empower patients by striking a balance between their medical indication and their personal preference in an attempt to guarantee the quality of life according to their own understanding. Moreover, the patient's context is in fact embedded in patients and the related person's narratives. And as a result, it can be identified through patient's residual function using our narrative analysis. So, the story, we first developed the kind of international demonstration model is in Yuli Psychiatry Hospital. This is a huge hospital. There are more than 10,000 people once upon a time, and short of manpower because nobody wants to stay there. It's really a madhouse, right? And with insufficient manpower supply out there. However, when people, a team, recognize, oh, well, there is reserve function in that severe mental ill patient. So then patient become manpower to manage their own life and take a part to support each other. So all of a sudden, the manpower from insufficient become oversupply. You know what I mean? So afterward, the new care provider team go to the community, persuade those community leaders, let them play a part in their small business. So nowadays, each year they earn 8 million NT dollars, Taiwanese dollars each year. So the way we provide them to create a supporting environment in neighborhood, in institution neighborhood, allow them to work there. That will be the second layer of the therapeutic community network building. And finally, we find that if we have a national effort, that we have the kind of network, then patient can go home. That was the secret story why American failed. So I think that here we can see the patient is relying but less dependency on the medicine. And also the UD community for the target patient population works a very important part for their symptom control. With support from personnel in UD therapeutic community, this patient take an active part in their own therapeutic protocol. The narrative competence of a psychiatric patient is an important foundation for shaping a collective life, whether they are in deteriorating or in recovering mode. So, and later on, we extended the kind of model for substance abusers. They are high-function patients, and we find that those are sources of this theoretical model, and there are structural activities. And we find that based upon, okay, so the therapeutic community here is a drug-free residential setting that uses a hierarchy model with a treatment stage that reflect increased level of personal and social responsibility. And how you go through the strategy, the narrative analysis will help you to reshape the best protocol or blueprint for each patient in their recovery mode. So along the line, the narrative of the residents, they are very coherent and go in depth into various life experiences. The residents regard this therapeutic model as a supportive environment to help substance abusers rebuild their social life with different skill training. This kind of culture of mutual support is very important for TC for therapeutic community for substance abuse. The new network formation is very important for substance abuse, right? Okay, afterward, we have a ADHD family support group, which is a hospice-based model. And Vincent, Jin Hong Chen, and me created this kind of model. It's a part Python. So there's the first stage, behavior therapy. Coping strategy help these children, ADHD, find a way to calm their mind and become absorbed in things that interest them and improve their ability to pay attention. And in the facility, the ADHD children search for their own life meaning. It also helps teacher and parent sympathetically understand their difficulty and communicate with them appropriately. It's wise to identify the strengths of different children in order to provide appropriate guidance, encouragement, and support. And so, the trust building process begins by developing parents' trust in their own children. After that, role models for daily life with ADHD kids are crucial for parents. Likewise, trust building efforts help to bind the whole family together and then to extend the support network first to school teacher and then to include children's classmates. It is clear that the support group members can appreciate the design, a supportive environment for these children. Finally, the support group is very valuable for mutual support and the practical assistance it provides. So, in a sense, we have a paper published. So we think that we care not only ADHD kids, but also their parents, especially those mothers. And we care not only here and now, but also long-term story. And we care not only their external experience, but also in the voice. We care not only clinical experience, but also the solid data to create knowledge. So in conclusion, we think that the common feature of this different model of therapeutic community is that they cleverly deliver the patient from their current physical, mental, and environmental constraints by finding potential life opportunity embedded in their narrative of each so-called mentally ill patient. These constraints allow their illness to grow out of control by limiting the life opportunities at a particular point of no return, in a manner that will be characterized by a virtuous circle of their life narratives. Along the line, this projected proposed community mental health as a learning paradigm that encompasses a situational and a relational approach for medical professionals in treating different kind of patients with a contextualized empowerment approach. So, this approach presents a new essence for mental health professionalism, which may contribute to exchange among regional professionals as well as protect human rights. In conclusion, Taiwan's experience can serve as evidence for patient-centered professional model, open a new horizon for gap in contemporary theory regarding professionalism. And we begin to build up the various kinds of network. Let me tell you that at the very beginning, which is 42 children wounded in Incheon Elementary School with sulfuric acid attack during the 1984. At that time, we highlight the importance of mental health. So we built the whole infrastructure since that time, 30 years ago. But this time, 4 killed, 21 wounded in Taipei subway knife attack. But however, afterward, under the new authoritarian regime in Taiwan, they did nothing. So, which is very important. Mental health is a matter of cultural identity, or it's just a matter of individual psychology. Nowadays, we have sufficient personnel to provide individual psychology. But however, our policy will reflect in what way we reflect on current Taiwanese regime, especially along the line of cultural identity. And we can see that after Incheon Elementary School, sulfuric acid attack, first, specific budget for mental care. Sunlight Foundation established by social worker affiliated to a leading university. Hospitals are required to establish a psychiatry department by Ministry of Health at that time. And now we can see, here is Taiwan, here is Thailand. Both societies go through a kind of social turmoil. But however, why Taiwan's economic growth is much better than Taiwan? There are significant problems in terms of political sphere. But however, the Department of Mental Health under Ministry of Health in Thailand make a significant difference, which is something different from the professional society in Taiwan. So we can see, nonetheless, Taiwan still suffers a series of gas explosions in southern Taiwan city of Kaohsiung has killed 28 people and injured about 300 in August 1. You can see the big metropolitan area become this kind. And also, Trans-Asia flight GT2 crash, likely due to bad weather in July 24. There are a lot of seemingly man-made deaths later on. And you can see this is a metropolitan area and what kind of chemical and oil pipeline spread in that beautiful city. So which is such a dangerous situation for Kaohsiung. But in a way, mental health could create a different mind of the urban planning horizon and the landscape. But in a sense, we find that compared to nowadays Indonesia government and the Thailand's government, we have much to learn about what we can share in the region. So a community-based international partnership become that we know that we have to overcome. The incompetence of the government become a destiny. But how we cover with the destiny become a very important common heritage among Southeast Asia. So we begin to build up a new program, and certainly they take a part with this our main partner. So here the National Center University, Heavy Medical University, and the National Thai University, we propose a kind of clinical practice-based bioethics education graduate program for that purpose. And afterward, based upon the clinical ethics and the new formation of the new sense of professionalism based upon the nowadays bioethics endeavor, we try to find the balance of globalization, which is regarding the liberal, the moment of liberation of the world, declaration of independence in the United States, and the Manifesto Community in 1847, which is a very important dimension that holds the society together. With the kind of global trend, how the Muslim talent become the essential part to hold a new sense of professionalism for Indonesia. I think that every country has to do the similar framework to engage their own culture with the kind of with their struggle of the globalization, trend of globalization. So, in that sense, the medical context should go through a knowledge management system with a social context in order to situate the professional reasoning in the fabric of forever changing social context, especially with the rise of genomic medicine and the information technology. Along the line, clinical ethics will be the foundation that pave a way for research ethics. Both become the foundation of professional ethics. And the most important goal will be the sustainable ethics that Dara has been mentioned from time to time. And here we have another, based upon the kind of workshop, we recent 5 years, we have the new workshop on hospice care and bioethics. The date for this year is December 15th and until the December 22nd. And if you have the time to see Taiwan, then you will have a chance to see this beautiful couple and all our personnel here. And this project was leading by Professor Hu, she will present later. So I think that my talk will serve as a kind of a grand illusion in Taiwan. And I think that the lovely couple present to you is a very important foundation before. Based upon that, we begin to dream our future. So later on, the presenter will tell you what's our future dream. And those are framework for our coming workshop. And thank you for all your attention.
Thank you. Are there any questions? Joffy, please.
I can really congratulate you for making wonderful benchmarks in this field. And for thanks for the good presentation also. And in the area in which I live, in my district or my state, I have found that the lower middle class or the poor people who have mentally ill children in their homes, they take it in a positive way, and they think that they should serve the mentally retarded child with all care and attention. And some sophisticated, maybe the above rich people, they send those mentally retarded children to the homes where they charge, and they also provide the rehabilitation.
Yes.
Okay. Now, first one question is, what is the attitude of the parents in Taiwan if they have a mentally ill child at their home? And number two, now, since I am involved in these activities, many of my friends tell me, if I die, or if my wife dies, who will look after this child? So many people come to me for solution, but neither I am a psychiatrist nor a rich man. So I can can you give them a model so that they can live as a community, so that they can help themselves in their future. Thank you.
Yes, thank you for your very important and wonderful questions. For question number one, I think that nowadays there are unchained movement in Southeast Asia. And I think that in Taiwan 30 years ago, we trained patients as well. Why? Because we want to protect them. But they are so unstable. So we train them because that makes us feel better, you know. But those families are so frustrated in the past. So along the line, how to let people have the new experience and let them have the idea change and let them know they can support each other. That will be much better. And somehow we may fear that poor family and poor people, they are the moral mentor for the whole society compared to those life led by so-called rich families. So that will be the way I address your question one. And for the question two, I think that the Japanese government will be the icon in the field. I think that institution also means that the strong state policy for welfare state. So I think that part was very, very important. Along the line, I think that institutional approach is inevitable. Thank you.
Dental and mental health are usually neglected in public health.
Yes.
And it's usually because it's so difficult to have a mental health network. But I think a very important concept is, what is your definition of mental health? Many of your activities were concerned with rehabilitation of patients who have mental diseases like schizophrenia.
Oh, definitely. Yes.
And like drug abuse.
Yes.
But mental health can be a lot broader than that.
Oh, definitely.
And it would
Yes.
require a lot of counseling activities,
Yes.
network within counselors, and even telephone hotlines. I don't know if suicide is a big issue there or not.
Definitely. Yes.
So how do you want to broaden the mental health, activities, and what's your definition of mental health? Is it psychosocial health, or is it not having a mental disease? How do you define?
Thank you. I think which is a very important question. First, it really depends upon our resources. So we definitely follow the DSM-4 guideline. That will be very important. Those fulfill the criteria are the people that need first aid. And secondly, along the line, the health promotion and the rehabilitation will be one story. I think which is very important that when Japan try to provide health services for the elderly, and then you feel that the community health promotion is equally to the kind of long-term care strategy development. I think that will be the wonderful idea that we learn from Japan and from United Kingdom. And thirdly, we think that every society has a kind of network. Those minded people are persons who suffer from the prodromal symptom. So in our network, at the very beginning, we have the teacher zone. that is a kind of mind person self-supporting network. They are not professional, but they function very well. So I think that how to recognize the reserve function in each party and let them contribute a part for the rehab and for the mental health promotion will be equally important. Yes.
Thank you.
Okay, thank you.
Thank you very